vaccinate you, Mark, with a component of the COVID-19 virus, the SARS-CoV-2. The important component is that spike protein. Because when you look at the virus under electron microscope, you have these spikes that stick out. That's the reason why you get the word coronavirus standing for crown. It looks like the spikes on a crown. Well, that particular spike protein is the thing you want the body to make an immune response against. So rather than getting involved in handling the virus, what happens as soon as the virus is discovered, the technology today allows us to get the full sequence of the virus in days as opposed to years. So then you publish the sequence, and anybody in any lab can pull the sequence out of the gene that specifically codes for the spike protein. So you don't have to touch the virus. You go in silico, in a computer, you pull out the gene, and you stick it into this messenger RNA. Now, the purpose of messenger RNA in your body is to code for all the different proteins that your body makes. So now you're going to take an artificially made RNA, you're going to stick this particular sequence in, and then you inject it into the body. It goes into a cell, and it starts pumping out protein. So the body sees the protein and says, I think that's the virus because it's a spike protein. But it isn't the virus. It's a harmless protein that you made very quickly. So to give the viewers and the listeners an example, on January the 9th, the Chinese put on a public database the sequence. On the 10th, we had a meeting with my team that said, we're going to take that sequence, we're going to partner with a company, Moderna, and we're going to maybe 3 or 4 days later meet and get the vaccine starting to be made. It's very simple. I mean, it isn't growing a virus. You just stick it in and bingo, you start making and producing the messenger RNA. Well, about 63 days later, 62 days later, we had enough of it to do a phase 1 trial. An absolutely world indoor record to go from the time you get a sequence to the time you have enough vaccine to do a phase 1 trial. A few months later, we were in a phase 3 trial. And then because there was so much infection in the community, a couple of months later, we started the phase 3 trial on July 27th. By the time you got to August, September, October, we had enough data so that by the time we got to November, we said, oh my goodness, we have a highly efficacious, safe vaccine that we're now going to start to administer in December. The technology that allowed that, Mark, is beyond unprecedented. It's something that if you had told me that 10 years ago when we were making vaccines for different things, I would have told you, Mark, I respect you, but there's no chance in the world that we're going to be able to do that. And it was done. And your point is an excellent one. If we're successful, which we're there, we just have to go through the motions of proving it now with large numbers of people, that we are able to really crush a disease like COVID-19, the way we did with smallpox and polio and measles. With this new technology, you're absolutely correct. It's such an adaptable technology that it would likely transform the way we look at and make vaccines.
So I've heard from a lot of people who have questions about a new type of vaccine that involves RNA or DNA, and why we can expect that this can be safe without having any issues down the line. So I'm curious to hear how you'd explain that scientifically and your thoughts on that concern overall.
Yeah, because we know what happens, from a lot of work in the animal models. So that RNA that pumps it out for a very limited period of time, enough to get a good immune response. And then the RNA degrades the way RNA generally degrades under most circumstances. So what the FDA has done is that they are not going to consider an EUA until 60 days following the time that half the people in the trial have received their last dose. And the reason the 60 days is the magic number, because when you look at the experience over decades with vaccines, the intermediate and long-term adverse events almost all occur between 30 and 45 days. So if you wait 60 days, you cushion it a little and overshoot a little. And if you don't see severe events during that time, it's extremely unlikely that you're going to see severe adverse events.
And just to clear up one point, I mean, my understanding is that these vaccines do not modify your DNA or RNA. So I think that's just an important point to clarify. If I'm getting anything wrong here, of course, correct me. But
No.
But just to make that clear.
No. First of all, DNA is inherent in your own nucleus cell. Sticking in anything foreign will ultimately get cleared. Messenger RNA is the messenger. It comes from the DNA to the RNA to the protein. Sticking an mRNA into you has absolutely nothing to do with your own DNA or your own RNA. It's going to perform its function, and then it's going to be degraded, and it's gone. It doesn't have any imprint on any genetic material of your own.
Good. Well, I'm glad we can clear that up. A number of people have also written in and asked, how do we get a clear answer on how long this immunity lasts? Right? If you're talking about, the effect going in and then potentially wearing off, does it look like this is the type of thing where we're going to need to get boosters regularly after the initial 2 doses? Or do we think that this will be effective for a long time?
Well, Mark, one of the things that we have to be honest about in science is that when you don't know the answer, you say you don't know. And I don't know how long the immunity is going to last with the vaccine. When you look at immunity to COVID, to coronaviruses in the past, they're not lifelong immunity, unlike measles, when you get infected with measles or when you get vaccinated with measles. So we would hope it's at least a few years. And if it does ultimately require a booster, fine. I think the first step, given the situation that we're in right now, is to show that it actually works. So I'm hoping that the immunity will be durable enough to get us through a couple of cycles. And if it isn't, we'll cross that bridge when we come to it and boost people.
So one question that I'm seeing in the comments are, do the vaccines from Pfizer or Johnson & Johnson, for example, have any known collateral effects or symptoms, like this person mentions a fever in adults or anything else like that?
Yeah. Well, it is not uncommon, Mark, when you're dealing with vaccines, that there are immediate effects, and then there are things that are more significant that might occur later. And that's the ones we spoke about that you can capture in that 60-day period. But with any vaccine, some more than others, when you get an injection of the vaccine, you induce a response. In some people, they don't feel anything. Others feel an ache in the arm. Some may feel an ache in the arm and kind of a little chilly feeling, almost like you have a flu-like syndrome. And in a minority of people, they'll get a fever. They'll actually get a fever for a day. Almost all of this goes away within 24 or at the most 48 hours. So we have to be honest when we tell people the adverse events, if you want to call them, are low grade. They're not serious, they're not prolonged, they're low grade. But to let people think that you get vaccinated and you don't feel anything, that's not the case. You do. What their body is telling you by that response is that it's responding well to the injection. It's making the kind of response that you want.
Yeah, so one other question that I've heard a number of times is, asking why is it necessary to store some of these vaccines at such cold temperatures? And in practice, doesn't the fact that some of them need to be stored at such cold temperatures make it pretty difficult to distribute the vaccine? How do you think about that in practice?
Well, there are 6 candidate vaccines that the federal government is involved in either helping develop or supporting the trial. 5 of them now are in either phase 3 or finished phase 3, or coming to the end, not totally finished, but coming to the end of phase 3. They vary in what we call their cold chain requirements. Some of them, as you mentioned correctly, require very, very low temperatures, like minus 70 Celsius and minus 90 Fahrenheit. And others require just a plain freezer, and some require just being in the refrigerator. It varies according to the formulation. I believe that the ones that really require that very stringent cold, if they study it more, it likely would not require it. But in the development of it, they did put it under those conditions. That makes it more difficult for that particular candidate to be distributed in a country or an environment that doesn't have easy access to cold chain capabilities. But in this country, there will be, according to Operation Warp Speed, the capability of doing the kind of storing that's necessary to do that. That is the Pfizer product. The Moderna product is less stringent. The J&J product is even less stringent when it comes to cold chain, and is going to be a great deal of variability. But you're absolutely correct. Sometimes a given vaccine, as good as it may be, would have to be utilized only in a circumstance where you can handle those requirements, where other vaccines may not require as stringent a cold chain capability.
Yeah. So, one thing that I just want to say is, and I worry about here, is that no intervention is ever going to be perfect, right? But just because something isn't perfect or may have some issues doesn't mean that it's still not significantly better than not getting it at all or not trusting it. And it seems like this is a fundamental question about science these days. And I'm curious if there's any kind of wisdom that you would want to share with people about kind of the perspective on risk benefit in thinking through this.
Well, you're onto something there, Mark, and that's something we deal with in medicine all the time. Because when you're dealing with either the treatment or the prevention of disease, that you're going to do interventions, and there are no interventions of anything that don't have some risk. It might be a minuscule risk, but it's nothing. It's nothing that is completely free of risk. You take an aspirin, there is a risk for some people for an aspirin. So the way we deal with it, we deal with what's called relative risk and risk-benefit relationship. So if you look at the risk, the relative risk of an adverse event with a vaccine, and look at the history of vaccinology, it is one of the safest interventions that you can do. If you look at the benefit is to you as an individual and to society, particularly in the context of this terrible challenge we're being faced with this horrible pandemic that this world, this planet is living through, that an intervention like a vaccine that historically has very, very little risk, the risk-benefit ratio overwhelmingly. But then you gave, well, wait a minute, some people say, well, this is a new risk. I'm bothered by it a bit. I mean, I don't know it. I really want an absolute safety at all. You got to think about the things that you do every day, the decisions that you make, about risks that you take, getting up in the morning, getting in your car and going to work, that the benefit of the getting to a job that's going to support your family is overwhelmingly better than the risk that you're going to get into a problem with driving to work. But yet you accept it. I mean, it's a risk that you accept. I think what we have to do is make sure we get people to understand that the relative risk of this compared to other risks is minuscule. When they understand that, they'll understand that it isn't zero, but it completely overwhelmed by the benefit that you would get.
Yeah, that makes sense. So I'm curious to move on to kind of manufacturing and availability of the vaccine. And I'm curious, what do you expect the trajectory of manufacturing these vaccines will be? And when do you expect most people will be able to get these vaccines?
Well, let's talk about the United States first and then globally. So right now, the federal government has contracted with multiple companies to make about 600 million doses of vaccine, which would be good enough for around 300 million people getting vaccinated. Hence, everyone that you would imagine that would want to get vaccinated in the country would have a vaccine. In December, the first of the high priorities, which would likely, and it's interesting that you asked that question now, Mark, because tomorrow, the Advisory Committee on Immunization Practices is meeting with the CDC to talk about what the recommendations of the different tiers of priority, which will likely be a combination of healthcare providers, frontline people who take care of patients, as well as those who are at a higher risk, like people in nursing homes and those types of situations. Then as we get into January, the next tier, and February and March, by the time we get to April, there would likely have taken care of all the high priority, and then the general population of the normal, healthy young man or woman, 30 years old, who's got no underlying conditions, can walk in to a CVS or to a Walgreens and get vaccinated. I would think as we get through April and May, that we likely would have, for those who want to get vaccinated, the overwhelming majority of the people that want to get vaccinated. The challenge is going to be to convince people to get vaccinated, because if you have a highly efficacious vaccine and only 50% of the country gets vaccinated, you're not going to have that umbrella of protection of herd immunity. What you really want is, one, what we have, a highly efficacious vaccine, but you want 75, 85% of the people to get vaccinated. If we get to that point, Mark, and people get vaccinated, by the end of the second quarter of the year, you could have enough protection in this country that the pandemic as we know it will be well suppressed below the danger point.
Got it. So more specifically, what do you expect the vaccine availability will look like, later this winter and then in the spring and then by the summer? When do you expect we're going to be at the point where everyone who wants to get the vaccine is able to do so?
Yeah, like I said, I believe that will be as we enter into and get to the end of the second quarter of 2021. Starting with April and going into May, June, July, by that time, if people want to get it, they can get it, and hopefully everybody would want to get it.
Good. So a lot of people also want to know, when should they get the vaccine? Is your perspective that if the effectiveness and safety data ends up as good as it looks now, then everyone should try to get this as soon as it's available? Or is there more nuance in how you think that people should think about this?
Well, each individual person, as we all know, is different, and they have their own assessment of what they want to do. There will be those people, and I believe it will be heavily weighted towards the elderly and those who have underlying conditions, who say, I cannot risk getting infected. I want to get it as soon as I possibly can. There are others that might be young, healthy individuals that say, I ultimately want to get it, but let me wait until 20, 30 million people have already gotten it. It still looks like it's really efficacious, and it doesn't look like there's any severe events. I'll get it. I may wait 2 or 3 months, but I'll get it. So I think that's going to be the dichotomy of the people who really feel that the risk for them is high enough they want to get it as quickly as possible, and then others who say, I want to ultimately get it, but I don't really need it right now.
Got it. And do you think that latter approach is fine for some people, or do you think that those people are making a mistake?
Well, I think for themselves, each individual person makes their own individual decision. I would like to see the overwhelming majority of the country vaccinated before we get to the end of the second quarter, because I would like to see children, adults, everyone so that when we get into the fall season, the children could feel really safe at going back to school. The teachers can feel safe that they're not going to get infected. We can get back to the economy being robust. Restaurants can open to full capacity. That's what I'd like to see. But you're not going to see it, Mark, unless the overwhelming majority of people get vaccinated. So in that sense, I would like to see the reluctant people get vaccinated sooner rather than later. If they want to wait a month or so, that's okay. That might be in accordance with the pace of being able to implement. But I don't want them to wait 6 to 8 to 9 months. I think they should do it within that period of the first 2 quarters of 2021.
Got it. And what do you think is the best argument to convince those people that taking the vaccine during that time frame is the right decision for their and their family's health?
Well, because as long as you're susceptible, you're part of the problem, not part of the solution. When you're protected, you're another person the virus can't impact. Whereas if you're vulnerable, even if you don't get a lot of symptoms, the fact that you've been infected means you are inadvertently propagating the outbreak. So if you want to be part of the solution, get vaccinated and say, I'm not going to be one of the people that's going to be a stepping stone for the virus to go to somebody else. I'm going to be a dead end to the virus.
Yeah. So there are a number of questions on the thread about herd immunity and what percent of our society we currently believe would have to be vaccinated for everyone to be generally safe. Do we know that? What's our current understanding of that?
We don't have a definitive percentage of that for this disease yet, because we're novices in this, because we've only been dealing with it for less than a year, 10 months. We have some pretty good information for other diseases. For example, measles, which is one of the most contagious viruses known to man. It has a vaccine that's about 97 to 98% effective. In order to get herd immunity, you've got to stay above 90% of the people vaccinated. If you don't get into the 80s, you're going to find out the kinds of outbreaks we saw in some of the communities in the New York City area a couple of years ago. With this vaccine and this virus, although I don't know definitively, Mark, what that percentage is, I would imagine it's somewhere between 75 and 85%, at least.
Interesting. All right, so I want to make sure that we get a chance to address some of the social equity issues around vaccine access as well. Because I know a lot of people would be willing to pay a lot of money to get a vaccine sooner, but how are we going to make sure that the people who need it the most can get it, including vulnerable populations, and not just in the US, but around the world? And there's a question in the comments here about whether any high-risk groups will get a priority on access to the vaccine.
Well, there's good news answers to all of your questions. So enough vaccine has been ordered and paid for to be able to get virtually anybody who needs a vaccine, who wants a vaccine in this country. I'll get to the global situation in a moment. In the distribution of vaccine, because once you start distributing it, on day one, you don't have enough vaccine for everybody. So you have to have that prioritization. Tomorrow, Tuesday, the ACIP, the Advisory Committee on Immunization Practices, will be meeting with the CDC to discuss what the various tiers of prioritization is. Healthcare workers, vulnerable people, essential workers, school teachers, children, on and on and on. So there will be a formula for that. And one of the things we have to do is to make sure that the healthcare setting in different parts of the country with different demographic groups doesn't get in the way of them getting vaccine in an expeditious manner. So that is going to depend very heavily on the local public health system to get the vaccines to the people who need it, because there certainly will be enough vaccine for people. We've got to get it to those who need it. and that will be heavily dependent on the local healthcare delivery system. So if all things work well, we know the doses are going to be delivered because we have a very good logistics system of doing that. Once it gets delivered to the places where it's supposed to be administered, that's another challenge to make sure it gets distributed to the people who really need it. That's for this country. If you really want to be free of the threat of COVID-19, this is a global problem with a global solution, which means we must be able, as a global community, to vaccinate the entire world. And we know from experience that certain countries don't have the capability of getting, making, or purchasing vaccine for their own population. So that's where you get a number of organizations, including Gavi, the WHO, and others, to get the developed nations that are rich nations to put in to make sure that enough vaccine is manufactured to the tune of billions and billions of doses so that we can do with COVID-19 what we did with smallpox and what we did with polio. In most countries, we're on the verge of eradicating it. And what we've done in many respects with measles, even though we still could do better with measles. Because I have always been of the feeling and the principle that health for the world should not be determined by the poorness or the lack of resources of a country, that we have a moral obligation as a global community of countries that have wealth to make sure that we eliminate this scourge from the entire world, not only from our own provincial environment.
Yeah, I think that makes a lot of sense, and I know we're running a little long here, but maybe just one or two more questions. I'm curious how you think about, going back to the question around risk-reward, how you think different demographic groups should think about the vaccine in their own personal plans. So, for example, one vaccine expert told me that he felt much more strongly that his older mother gets the vaccine than that younger kids get it, because, as you said before, an older mother would be in a higher risk group than that potentially could suffer more. But are there other ways that you think that different demographic groups should think about this as we near the availability of the vaccine? How different groups should think about getting the vaccine?
Well, there's strategic vaccinations. For example, you made an interesting story there that it may be that the older person doesn't respond very well and is not protected, and it may be even better to protect the people that grandma is going to come into contact with. So maybe if you vaccinate the younger person, you prevent him from spreading the infection to her. That has been one of the strategies for a number of vaccines, to vaccinate children even though they don't get as sick as the elderly, in order to prevent them from transmitting it to the elderly. That doesn't seem to be the case with COVID-19. But you make a good point. I mean, I'm concerned more about vaccines for different demographic groups that normally are reluctant to get vaccinated, like the minority communities. We absolutely, African Americans and Latinx, suffer disproportionately from COVID-19. And yet, those are the populations, particularly African Americans, who have skepticism about government-sponsored medical programs, for good reason, because the extraordinarily tragic story of Tuskegee still looms large in the memory of some of the older individuals that pass it down to the younger generation. So we've got to reach out and engage them at the community level to make sure that reluctance, for reasons that are understandable, don't prevent people who really need the vaccine from getting the vaccine.
Thanks. I think that makes sense. And Doctor, I know we are running short on time. So before wrapping up, I just wanted to ask, are there any other words of wisdom that you would like to share with the millions of people who will watch this and just want to know how we're going to get through this?
Yeah, well, thank you for giving me that opportunity, Mark. We are all living through a terrible ordeal that is not over. This issue of COVID fatigue that really is wearing and tearing at us, both from a personal standpoint, from an economic standpoint. People are suffering in so many different ways from this terrible experience we're going through. If you want to call it word of wisdom, it's more word of encouragement. This will end. We've got to hang in there together and take care of each other. It will end. The vaccines are on the immediate horizon to be starting to be distributed in the month of December. Tomorrow's December the 1st. As we get to the middle and end of December, we're going to start getting vaccines distributed all through January, February, March, April. So rather than getting discouraged, which is an understandable emotion to a terrible ordeal that we've all been through, hang in there. The end is in sight. It's going to get better and better, even though, as Mark pointed out, we're on a really serious inflection of the curve, that we can do something about blunting that curve by doing the fundamental public health measures. That as we do it, that curve will bend, it'll start coming down, and as vaccines kick in, we're going to start seeing a dramatic change. So my word of encouragement is that let's all hang in there together. We are going to get through this, guaranteed.
All right, Dr. Fauci, as always, thank you for this discussion. And I think I speak for most Americans when I say this, but thank you for your leadership and service to our country through this difficult period. We appreciate it. I personally appreciate it. And I hope you stay good. And I hope to everyone watching this that you all stay healthy and good. And I will see you all soon.
Thank you, Mark. Thank you for being the opportunity to be with you. I really appreciate it. Thank you.